Welcome back. Part 3, the leukemias and marrow failure. We start with an empty marrow, separate acute from chronic leukemia, flag the one leukemia that is a true emergency, and finish with the myeloproliferative neoplasms. Let's go. We start with pancytopenia, low counts across the board. The bone marrow biopsy splits the causes. Is the marrow empty, dysplastic, or packed with blasts? Aplastic anemia is an empty marrow. The biopsy is hypocellular and fatty. You get pancytopenia with a low reticulocyte count, and there are no blasts and no splenomegaly. Myelodysplastic syndrome (MDS) is a dysplastic ineffective marrow. It makes cells but badly, so you see cytopenias with dysplastic forms, and it can evolve into leukemia. Acute leukemia is a marrow replaced by blasts, presenting with infection, bleeding, and bone pain. AML often shows our rods, while ALL shows TDT-positive lymphoblasts. So an empty fatty marrow is aplastic anemia, dysplasia is MDS, and blasts are acute leukemia. Now acute versus chronic leukemia. The split is maturity. Are we seeing immature blasts with rapid marrow failure, or mature clonal cells building up more slowly? Acute leukemia means blasts and rapid marrow failure. ALL is lymphoblast disease, classically a child with TDT-positive blasts. AML is myeloblast disease, usually an adult with our rods and myeloperoxidase positivity. Chronic leukemia means mature clonal cells that accumulate slowly and are often found incidentally. CLL is a disease of older adults with fragile mature lymphocytes that smear into smudge cells. CML is a granulocyte expansion driven by the BCR-ABL fusion, with basophilia and a low leukocyte alkaline phosphatase. So blasts mean acute, while mature cells, whether smudge cells or BCR-ABL, mean chronic. Within AML, one subtype is a true emergency. When an AML patient is bleeding with a low fibrinogen, which one do you fear? Acute promyelocytic leukemia, APL, is the emergency. It is full of abnormal promyelocytes with bundles of our rods driven by a translocation between chromosomes 15 and 17 that fuses PML and RARA. The promyelocytes spill their granules and trigger DIC, so you see a low fibrinogen and a high D-dimer with bleeding. The life-saving move is all-trans retinoic acid, which forces the cells to mature. Other AML subtypes have myeloblasts with myeloperoxidase positivity, and maybe our rods, but not that promyelocyte and DIC signature. So promyelocytes with the 15-17 translocation and DIC are APL, treated with all-trans retinoic acid. Now a sky-high white count made of neutrophils. Is this chronic myeloid leukemia or a Leukemoid reaction, an over-the-top but benign response to infection? Two tests separate them. Chronic myeloid leukemia is clonal, driven by the BCR-ABL fusion from the Philadelphia chromosome, a translocation between chromosomes 9 and 22. It gives a huge granulocyte count with basophilia and splenomegaly, and the leukocyte alkaline phosphatase score is low because the cells are neoplastic. A Leukemoid reaction is the benign mimic, a massive but reactive neutrophilia from infection or inflammation, with toxic granulation and dull bodies, no BCR-ABL, and a high leukocyte alkaline phosphatase score, because these are healthy neutrophils responding to stress. So a low LAP with BCR-ABL is CML, while a high LAP with an infection is a Leukemoid reaction. Now too many red cells, a high hematocrit. The single best test is the erythropoietin level. Is it suppressed or is it driving the red cells up? Polycythemia vera is a primary myeloproliferative neoplasm. The marrow makes red cells autonomously, driven by a JK2 mutation, so the erythropoietin level is low by feedback. Clues are aquagenic pruritus, itching after a hot shower, facial plethora, splenomegaly, and often a high white count and platelet count too. Secondary polycythemia is erythropoietin driven, chronic hypoxia from smoking, sleep apnea, or high altitude, or an erythropoietin secreting tumor raises the hormone and the red cells follow. So a low erythropoietin with a JK2 mutation is polycythemia vera, while a high erythropoietin is secondary. Last pair, both cause cytopenias, but the marrow and the spleen look completely different. Is the marrow scarred with a massive spleen or simply empty? Primary myelofibrosis is a myeloproliferative neoplasm that scars the marrow with fibrosis. So the aspirate is a dry tap. The blood production gets pushed out to the spleen and liver, giving massive splenomegaly and a leukoerythroblastic smear. Teardrop-shaped red cells, nucleated red cells, and immature granulocytes with JAK2, CALR, or MPL mutations. Aplastic anemia is the opposite picture, an empty hypocellular fatty marrow with pancytopenia and low reticulocytes, but no splenomegaly and no teardrop cells. So teardrops with a dry tap and a big spleen is myelofibrosis, while an empty marrow with no spleen is aplastic anemia. Lock it in. Pancytopenia, an empty fatty marrow is aplastic anemia, dysplasia is MDS, blasts are acute leukemia. Acute versus chronic. Blasts are acute, mature smudge cells or BCR-ABL are chronic, and within AML, promyelocytes with the 15-17 translocation, and DIC are acute promyelocytic leukemia, treated with all-trans retinoic acid. High white count. A low leukocyte alkaline phosphatase with BCR-ABL is CML. A high score with an infection is a Leukemoid reaction. High hematocrit. A low erythropoietin with JK2 is Polycythemia vera. A high erythropoietin is secondary. And cytopenias with teardrop cells, a dry tap, and a big spleen are myelofibrosis, while an empty marrow with no spleen is aplastic anemia. That is part 3. Part 4 finishes with the lymphomas and plasma cell disorders. See you there.